Greetings, everyone. Today we are going to talk about disc disease. Disc disease is extremely common. It occurs in teenagers, people in their 20s, 30s, and even in people in their 90s. Disc disease can affect individuals of all ages. The youngest patient I have treated was 10 years old. I have also treated many elementary school students, age 12 or 13, who developed disc disease, causing their spines to become crooked or hunched and resulting in significant pain. We also see many patients in their 90s. Even at the age of 90, a sudden strain can cause a disc to herniate, making the back hunched, preventing normal walking, and forcing patients to rely on a cane. Therefore, disc disease treatment is something that everyone may need. However, many people have fears. They ask, won't there be side effects after disc surgery? They also ask, if I undergo disc surgery, will I suffer from lifelong back pain due to complications? Many people have these fears. But when a disease is properly treated, a patient can return to a completely normal life. That is why today I will talk about disc surgery techniques that do not cause damage. In a normal spine, there are rectangular vertebrae, and between them is a white, lens-shaped disc that acts as a cushion. These images are of real human bodies. They were taken at the Department of Frozen Anatomy at Uppsala University in Sweden. The red rectangles represent the vertebrae. Between these red rectangles, the white disc acts as a cushion, and behind the vertebrae and the disc lies the spinal nerve. That structure is the spinal nerve. Because the spinal nerve is located directly behind the disc, when a problem occurs in the disc and the nucleus pulposus escapes, the nerve becomes compressed. Please look at the center image. The vertebrae are located above and below, and the white disc in the center is shown in close-up. Inside the disc is a white, tube-like nucleus pulposus that functions as a jelly-like cushion. Surrounding this nucleus is a fibrous ring, approximately 1 centimeter thick. This fibrous ring is torn. The tear at the front is small, but if you look in the direction of the arrow, the tear at the back is much larger. When the annulus fibrosus tears, bleeding occurs. You can see red discoloration at the torn portion of the annulus fibrosus. Through this tear, disc material escapes and herniates. The image on the right is an MRI showing a herniated disc. In this MRI, you can see the rectangular vertebrae with white lens-shaped discs between them. However, at the L4-L5 level, the white disc has become dark due to damage, and fragments of the dark disc have herniated toward the nerve. The nerve, which should normally run straight down behind the vertebrae and disc, is severely compressed at the L4-L5 level. Because the dark disc has herniated, the nerve is compressed, resulting in disc-related symptoms. The most characteristic symptom of a herniated disc is low back pain. Low back pain is accompanied by pain radiating down the leg. Because the pain spreads to the buttock, thigh, calf, ankle, sole, and top of the foot, it is called radiating pain. This is why it is also referred to as sciatica. The term sciatica refers to pain that originates from the hip area and radiates down the leg. Therefore, the key features of disc disease are low back pain and sciatic nerve pain in the leg. The pain becomes worse when bending forward. Leaning forward increases discomfort. When sitting for long periods, leg numbness and pain worsen. This is because prolonged sitting increases pressure on the disc, causing further herniation. As a result, the nerve becomes more compressed. Therefore, patients find it difficult to sit still for long periods. Some patients find that after sitting for a long time, their back does not straighten immediately when they stand up and requires time to adjust. They often place a hand on their lower back, like the man shown in the image. When disc disease becomes chronic, patients may continue daily activities such as exercising, playing golf, or working. After physical activity or labor, they often say that they have sprained their back. They may think, why did I strain my back muscles like this? They may experience severe back pain for several days and believe it is just a muscle strain. In reality, this occurs because disc disease was already present. After that, patients become reluctant to lift objects. Because strength in the back decreases, even men may ask their spouses to lift heavy items, and they begin to avoid lifting. It also becomes difficult to maintain the same posture for a long time. When disc disease develops, daily life and work are affected. More importantly, although exercise is necessary for good health, it becomes difficult to exercise. Of course, in severe disc disease, walking can also be affected. Walking for long distances becomes difficult. In such cases, causal treatment is required. By treating the underlying cause of disc disease, patients can recover from depression and regain their health. Waiting for the condition to heal on its own is not the right approach. The diagnosis of a herniated disc begins with self-assessment. This is called the straight leg raise test. Lie on your back and lift one leg while keeping the knee straight. A person without disc disease can raise the leg to 80 or 90 degrees without pain. There is no pulling sensation. However, a person with disc disease begins to feel pulling pain at around 30 to 60 degrees. When the raised leg is bent again, the discomfort improves. By performing this test, one may realize that disc disease is present. The next image shows me examining a patient. I am pressing down on the patient's big toe using my little finger. In a healthy person, the big toe resists firmly and does not move. However, in a patient with disc disease, the big toe collapses easily. Even when pressed by a weak little finger, the toe loses strength. This indicates that the disc herniation has progressed. However, a definitive diagnosis requires an MRI. Discs are composed of soft tissue. The nucleus pulposus and the annulus fibrosus are soft, jelly-like structures. Because these structures are soft, they can be clearly visualized only on MRI. Nerves are also visible only on MRI. X-rays, unlike MRI, cannot show nerves. On MRI, you can clearly see the disc positioned like a lens between the vertebrae. In this patient, at the L3-L4 level, the disc has ruptured and is compressing the nerve behind it. The dark disc material is pressing into the white nerve area. At the L4-L5 level, the disc has herniated toward the front. Disc herniation toward the back must be treated because it compresses the nerve. When nerves are compressed, various symptoms occur, so the root cause must be treated. However, what is located in front of the disc? The intestines and internal organs. Because the large intestine, small intestine, and stomach are located in front of the disc, forward herniation can often be left untreated. It usually does not cause significant symptoms. Although back pain may occur in some cases, the front of the disc generally lacks pain-sensitive nerves, so pain is often not perceived. Therefore, treatment focuses on the disc herniating toward the back. If the disc is examined in cross-section, it appears round like a bun, with a Y-shaped vertebral structure behind it. Between these vertebral structures lies the nerve. On CT scans, calcified discs appear white, while soft disc material appears gray as it protrudes. CT scans are useful for determining whether a disc is soft. Soft disc herniations can be effectively treated with endoscopic laser surgery without side effects. However, in cases where the disc has become hardened and appears white like bone, as shown in the image on the right, a microscopic laser approach is preferable. This is because hardened bone must be removed using specialized instruments. With microscopic laser surgery, problematic bone can be precisely removed. In some cases, a high-speed diamond drill is used to carefully shave the bone, similar to peeling an eggshell, which is why microscopic techniques are beneficial. Next, why is nerve imaging necessary? Unlike MRI or CT, nerve imaging shows the entire course of the nerve. In this patient, the nerves are blocked at the L3-L4 and L4-L5 levels. When nerves are blocked, patients experience back pain and leg pain, and paralysis may occur, making causal treatment necessary. There are cases in which disc disease requires surgery as causal treatment. When pain is so severe that even opioid analgesics or nerve blocks fail to provide relief, the disc problem must be corrected. Treating the cause results in immediate pain relief, and such severe pain should not be left untreated. In these cases, same-day causal treatment is often required. Even in the absence of pain, if lower body paralysis occurs, walking becomes difficult. Lower body paralysis does not always mean complete immobility. Incomplete paralysis may present as unsteady walking, staggering when trying to go to the bathroom, or walking as if intoxicated. Difficulty standing on one leg or maintaining balance is also considered paralysis. Incomplete paralysis can sometimes progress to complete paralysis. In such cases, prompt causal treatment is essential. If the ankle does not move properly, drags during walking, or the knee buckles, early surgery can fully reverse the paralysis. Some patients experience bladder or bowel dysfunction. When a disc suddenly herniates, patients may find it difficult to urinate. They may strain severely to pass only a few drops of urine or require enemas for bowel movements. These symptoms indicate serious nerve involvement. Specifically, the cauda equina, a bundle of nerves resembling a horse's tail, is severely compromised. If treated within 24 hours, full recovery is possible. This requires immediate transport by ambulance and same-day treatment. Chronic disc disease may also require surgery. If chronic disc disease causes persistent back pain and leg numbness, it should not be left untreated for more than 3 months. After 3 months of nerve compression, the nerve fibers can become adhered and damaged. It is similar to how hair becomes tangled when honey is applied. In the same way, prolonged compression causes nerve bundles to become entangled. After this point, even if the cause is removed, residual symptoms may remain. These include persistent numbness, cold sensitivity, and abnormal sensations in the legs. These are permanent sequelae. Therefore, to recover fully without lasting side effects, chronic disc disease should be treated within 3 months. Causal treatment is necessary. A long-term study in the United States followed disc disease patients for 10 years. After 10 years, both patients who underwent surgery and those who did not eventually recovered. However, those who endured the condition without surgery developed various disabilities. Although the disc healed and pain subsided, residual deficits remained. They experienced poor walking ability, numbness, and impaired toe movement. In contrast, patients who underwent surgery within 3 months recovered without sequelae. Their quality of life was completely different. Those who delayed treatment lived for 10 years without proper activity, whereas patients who received causal treatment returned to normal life quickly. There are additional situations in which surgery should be performed promptly. Planned causal treatment is necessary when motor weakness or sensory loss is present in the legs, ankles, or toes. In the image, the patient is touching the calf. Diminished sensation or difficulty walking quickly indicates nerve dysfunction and requires fundamental causal treatment. There are 2 main types of disc surgery. The traditional method involves removing the disc entirely to prevent recurrence. This method is based on fear of recurrence, leading surgeons to remove as much disc material as possible. The second approach preserves the disc, leaving its cushioning function intact, and removes only the herniated fragment compressing the nerve. I believe the traditional disc surgery method should be avoided. Preserving the disc allows patients to return to a normal life. Why does the traditional method remove so much disc tissue? If you look at the cross-sectional image, you can see the yellow nerve structures. There are nerve roots on both sides and a central bundle of cauda equina. At the site of disc herniation, the annulus fibrosus is present. The annulus fibrosus is very thick, approximately 1 centimeter, similar to a car tire. Traditional surgery involves cutting a nearly 1 centimeter opening in this thick annulus. A scalpel is used to excise the annulus to remove the disc. After creating this opening, forceps are used to remove disc material, and the remaining disc is often scraped out. This is done because the opening in the annulus is large. If disc material remains, recurrence can occur within weeks, months, or even years. Once the annulus fibrosus is cut, it does not heal or close. The opening remains permanently. As a result, physical activity such as golf or heavy lifting can easily cause recurrence. Even some spine surgeons have experienced multiple recurrences. The second major problem with traditional surgery occurs when there is a tear in the front of the annulus fibrosus. In such cases, surgical forceps can inadvertently pass through the disc into the abdominal cavity. In front of the disc are internal organs and major blood vessels, including the aorta and vena cava. Although rare, vascular injury can occur. In these rare situations, patients may require abdominal surgery to repair damaged blood vessels. For these reasons, I do not recommend traditional disc surgery.